Okay, so we shall be talking about immune thrombocytopenia purpura, also known as ITP, and otherwise known as just immune thrombocytopenia, as the purpura part is variable. Now, if we try and define this pathology, we can simply just look at the name itself. Immune here means that there is an immune response occurring. Now, we shall discuss these later in the etiology. Thrombocytopenia can be divided into three parts. Thrombo means platelets, cyto means cells, and penia means low. So in this case, we have an immune response which results in low platelets. The etiology can be classified depending on patient presentation into the acute and chronic forms. In the acute form, patients are usually under the age of 10 years, and the cause is usually post-infectious. So some sort of molecular mimicry has occurred which resulted in the autoimmune response, which causes the immune thrombocytopenia purpura. Other causes in children or in the acute form could be post-immunization, as well as infections such as measles. In the chronic form, the risk factors here are women of childbearing age, as well as those over the age of 65, so in adults over the age of 65. And this can be subdivided into the primary and the secondary causes. Primary cause, as we all know, is idiopathic, which means we don't know why it has occurred, but for some reason it has. Secondary is usually due to a secondary pathology, usually autoimmune ones, such as lupus and thyroid disease. Other causes include cancers, including chronic lymphocytic leukemia and solid tumors, and also infections such as HIV. So now that we understood the etiology, what of the pathophysiology? As with a lot of conditions in medicine, the pathophysiology is not completely understood. However, a few groups and a few studies have shown three possible mechanisms. Indeed, these mechanisms could all be occurring simultaneously. Now, the first proposed mechanism is where plasma cells, and specifically splenic ones, produce antibodies of the IgG form which target specific antigens of platelets, and these primarily are the GP2B, 3A, although they can be any other antigen. These are then labeled in the bloodstream and are picked up by the macrophages of the spleen and are subsequently destroyed, leading to a thrombocytopenia or a low platelet count. The second mechanism by which immune thrombocytopenia can occur is by inhibition of platelet production due to suppression of normal megakaryocyte development. So we have an immune response which resulted in suppression of megakaryocytes, and this in turn leads to low platelets. As we all know, megakaryocytes are the precursors of platelets. The third mechanism is due to T-cell mediated destruction of platelets and megakaryocytes in the bone marrow. So again, we have an immune response which resulted in T-cells targeting megakaryocytes and platelets within the bone marrow, and again this results in low platelets. These are the three mechanisms which have been proposed and investigated in the literature. The clinical features patients present with are primarily due to low platelets. Patients can present with variable signs of bleeding. Most commonly they present with petechiae and purpura. Petechiae are the small non-blanching lesions caused by intradermal bleeding, whereas purpura are usually larger lesions caused by bleeding within the skin. Patients can also occasionally present with hemorrhagic bullae. Other clinical features include epistaxis, easy bruising, and menorrhagia. Rarely, patients can present with hemorrhage or splenomegaly. However, this is extremely rare. Now, in terms of investigations, you would want to confirm that there is a thrombocytopenia. You would do this by conducting a full blood count. This will show an isolated low platelet level. Now, if you suspect a secondary cause, you might want to do additional investigations, for example, thyroid function tests, HIV serology, and if you suspect a cancer, you might want to do specific investigations for cancer, for example, a bone marrow biopsy. If you were to do a coagulation screen, what do you suspect you would find? Pause the video and have a think. Now, the PT and the APTT, as part of the coagulation screen, would both be normal. And the reason for this is that immune thrombocytopenia purpura is a pathology of primary hemostasis rather than secondary hemostasis, and thus the coagulation cascade remains intact, hence why the PT and the APTT are both normal. Treatment depends on various factors. It depends on whether the patient is a child or an adult, and if the patient is an adult, is the patient female and pregnant. In addition, it depends on whether the patient is showing any symptoms, and also depends on whether this is an acute or a chronic diagnosis. Now, if a child presents to you and the child is asymptomatic or presents to you with minor bleeding, for example, petechiae or purpura, you simply just want to observe that child. However, in severe cases or in very rare cases, if a child presents to you and the child is symptomatic, aka has severe bleeding, then you obviously want to intervene here. And the way we intervene is in the form of corticosteroids or IVIG or anti-D immunoglobulin. Now, recent studies have shown that the anti-D immunoglobulin is superior to the IVIG. Now, if an adult presents to you with a platelet count of more than 30 and is asymptomatic, again, you just want to observe that patient. However, if the platelet count again is more than 30 but the patient is symptomatic, then you want to use the same treatment as we previously mentioned of corticosteroids, IVIG, and anti-D immunoglobulin. Now, if the patient presents to you with a platelet count of less than 30, you want to use the same interventions. However, you would also consider using platelet transfusion. In chronic or persistent situations, the hematologist might consider using mycophenolate, rituximab, and as second-line therapy, they might consider doing a splenectomy. In pregnancy, these treatments are contraindicated. So in this case, you would want to use high-dose corticosteroids, IVIG, and also, although you don't really want to do surgery in patients that are pregnant, consider a splenectomy. Now, if the patient, whether it is a child or an adult, presents with life or organ threatening bleeding, you obviously want to activate the major hemorrhage protocol, as well as use IVIG plus corticosteroids plus platelet transfusion. You might also consider using an antifibrinolytic